Heart failure with preserved ejection fraction, HFpEF, is defined by an ejection fraction of 50% or greater, though some sources use a cutoff of 40% or above. Also known as diastolic heart failure, HFpEF represents a condition where the heart's systolic function, ability to contract and pump blood, remains preserved. But diastolic function, ability to relax and fill with blood, is impaired, leading to the classic manifestations of heart failure despite a normal ejection fraction. The primary pathophysiologic defect in HFpEF is impaired ventricular relaxation and increased chamber stiffness, often described as a stiff heart that won't relax. Unlike systolic heart failure, the problem lies not with the heart's ability to contract, but rather with its ability to fill during diastole. The ventricle cannot relax properly, which prevents adequate filling and leads to elevated filling pressures despite maintaining normal contractility, ultimately causing the backward congestion and symptoms characteristic of heart failure, even though the ejection fraction remains preserved. The characteristic structural cardiac change seen in HFpEF is concentric left ventricular hypertrophy, which features thickened ventricular walls with a normal or small LV cavity size. This pattern results from chronic pressure overload, most commonly due to long-standing hypertension, and stands in stark contrast to the structural changes seen in HFrEF, where the left ventricle becomes dilated with thin, stretched walls. This concentric remodeling pattern reflects the heart's adaptation to chronic afterload stress and contributes to the increased chamber stiffness that characterizes the diastolic dysfunction in HFpEF. Hypertension is the most important risk factor for HFpEF, present in 80 to 90% of cases, and is essential to consider when evaluating patients for this condition. The pathophysiologic link is direct. Chronic hypertension leads to concentric left ventricular hypertrophy, which in turn causes diastolic dysfunction and the development of HFpEF. Given its central role in the disease process, aggressive blood pressure control is a cornerstone of HFpEF management, with a target blood pressure of less than 130 over 80 millimeters of mercury to help prevent disease progression and potentially reverse some of the maladaptive cardiac remodeling. HFpEF is a systemic disorder characterized by multiple comorbidities that are almost always present together. The six major comorbidities include hypertension, present in 80 to 90% of cases and the most important; obesity, a major contributor; diabetes mellitus; atrial fibrillation, occurring in 50 to 60% of patients; chronic kidney disease; and COPD or sleep apnea. This clustering of metabolic and cardiovascular conditions reflects the fact that HFpEF is not simply an isolated cardiac problem, but rather part of a broader syndrome of systemic metabolic dysfunction and inflammation, which is why comprehensive management of all these associated conditions is essential for optimal patient outcomes. The S4 gallop, also known as an atrial gallop, is the classic heart sound associated with HFpEF and diastolic dysfunction. This sound occurs when the atrium contracts forcefully against a stiff, non-compliant ventricle, creating the characteristic Tennessee rhythm pattern, S1 to S4 to S2. While an S3 gallop can also occur during decompensation, the S4 is more characteristic of diastolic dysfunction and serves as an important bedside clinical clue. A helpful mnemonic to remember this association is that S4 stands for stiff ventricle, directly linking the physical exam finding to the underlying pathophysiology of impaired ventricular relaxation and increased chamber stiffness in HFpEF. The location of the point of maximal impulse, PMI, differs significantly between HFpEF and HFrEF. and can serve as a valuable physical examination finding to help distinguish between the two types of heart failure. In HFpEF, the PMI remains in its normal position at the fifth intercostal space, along the midclavicular line, because the concentric hypertrophy results in thickened walls, but maintains a normal or small cavity size without displacement. In contrast, HFrEF features a PMI that is displaced laterally and inferiorly with a sustained diffuse impulse, reflecting the dilated left ventricle that physically pushes the apex of the heart outward. This simple bedside finding provides an important clinical clue that can help clinicians differentiate between preserved and reduced ejection fraction heart failure even before obtaining an echocardiogram. Flash pulmonary edema refers to sudden, severe pulmonary edema that is often associated with hypertensive emergency and has a particularly strong connection to HFpEF. In patients with HFpEF, the combination of an already stiff ventricle and an acute elevation in blood pressure creates a situation where the heart cannot accommodate the increased afterload, leading to a rapid rise in filling pressures and sudden pulmonary congestion. The classic scenario involves an elderly patient with underlying hypertension who develops acute severe dyspnea as their blood pressure spikes. Treatment focuses on rapidly reducing the elevated filling pressures and blood pressure through the use of IV nitrates, which reduce both preload and afterload, diuretics to remove excess fluid, and aggressive blood pressure control to restore hemodynamic stability. The diagnosis of HFpEF requires three essential criteria: the presence of signs and symptoms of heart failure, a preserved ejection fraction of 50% or greater on echocardiography, and objective evidence of diastolic dysfunction or elevated filling pressures. However, HFpEF is fundamentally a diagnosis of exclusion, meaning that clinicians must also rule out other conditions that can present similarly, including valvular heart disease, such as aortic stenosis or mitral regurgitation, pericardial disease, such as constrictive pericarditis or tamponade, and high-output states, such as severe anemia, thyrotoxicosis, or arteriovenous fistulas. Only after excluding these alternative explanations can a definitive diagnosis of HFpEF be made, ensuring that the heart failure symptoms truly stem from primary diastolic dysfunction rather than another underlying cardiac or systemic condition. Both HFpEF and HFrEF present with elevated BNP and NT-proBNP levels, but HFpEF typically demonstrates lower levels than HFrEF, with diagnostic cutoffs of BNP greater than 35 picograms per milliliter and NT-proBNP greater than 125 picograms per milliliter supporting the diagnosis. The lower levels in HFpEF occur because the ventricle is not dilated, resulting in less ventricular wall stress compared to HFrEF, and because obesity, which is common in HFpEF patients, tends to blunt BNP elevation. Despite these relatively lower values, BNP and NT-proBNP remain clinically useful in HFpEF due to their high negative predictive value for excluding heart failure entirely. An important exam pearl to remember is that finding an elevated BNP or NT-proBNP in a patient with a normal ejection fraction should immediately raise suspicion for HFpEF, prompting further evaluation for diastolic dysfunction. Common EKG findings in HFpEF include left ventricular hypertrophy, LVH, left atrial enlargement manifesting, atrial fibrillation, which is very common in this population, and nonspecific STT wave changes. While none of these findings are specific for HFpEF and cannot independently establish the diagnosis, they support the overall clinical picture and reflect the underlying pathophysiology of the disease. The LVH pattern corresponds to the concentric hypertrophy seen on echocardiography. The left atrial enlargement reflects chronic elevation of left atrial pressures from the stiff left ventricle, and the high prevalence of atrial fibrillation results from the structural and electrical remodeling of the chronically stretched atria. These EKG abnormalities, when found in the appropriate clinical context, strengthen suspicion for HFpEF and help guide further diagnostic workup. The acute management of decompensated HFpEF is identical to that of HFrEF, focusing primarily on treating volume overload and supporting oxygenation. The mainstay of therapy is intravenous loop diuretics, typically furosemide, to reduce pulmonary congestion and peripheral edema. Supplemental oxygen should be provided if the patient is hypoxic to maintain oxygen saturation above 90%, and 4-nitroglycerin should be administered in cases of concurrent hypertension or flash pulmonary edema to rapidly reduce preload and afterload. Close monitoring of fluid status through intake and output measurements and daily weights is essential to guide diuretic therapy and assess response to treatment. Despite the different underlying pathophysiology between HFpEF and HFrEF, there is no difference in acute management approaches, as both conditions present with similar volume overload and congestion that require immediate attention. SGLT2 inhibitors, specifically empagliflozin and dapagliflozin, represent the only medication class with proven mortality benefit in HFpEF, marking a significant breakthrough in the management of this condition. The Emperor-preserved trial for empagliflozin and the Deliver trial for dapagliflozin both demonstrated reduction in cardiovascular death and heart failure hospitalizations, leading to a Class 1 recommendation in the 2022 guidelines. This represents a paradigm shift in HFpEF treatment, as historically no medications had been shown to improve survival in this population. Unlike HFrEF, where multiple drug classes reduce mortality. Given that these are relatively recent developments, this information is particularly high yield for current board examinations and represents an important update that distinguishes contemporary HFpEF management from older approaches that focus solely on symptom relief and comorbidity management. ACE inhibitors, ARBS and ARNIS, have not been proven to reduce mortality in HFpEF, representing a major exam trap, since these medication classes are life-saving in HFrEF. Multiple landmark trials have demonstrated neutral results, including PEP-CHF with perindopril, I-Preserve with irbesartan, and Paragon-HF with sacubitril/valsartan, all failing to show mortality benefit despite the clear survival advantages these drugs provide in reduced ejection fraction heart failure. However, these medications may still have a role in HFpEF management for secondary indications such as hypertension control, promoting LVH regression, and potentially providing symptom management, even though they do not improve survival. This distinction between HFpEF and HFrEF pharmacotherapy is critical for board examinations, as students must recognize that the guideline-directed medical therapy proven effective in HFrEF does not translate to mortality benefits in the preserved ejection fraction population.